Welcome back students. Now in this video let's discuss about pelvic organ prolapse. Most of the students feel this topic very difficult, but in this video I will try my best to make the concept as easy as possible. Okay, now without any further delay let's start our topic. So what exactly I mean by pelvic organ prolapse? In the name itself it's very clear that the pelvic organs are getting prolapsed. So what is that pelvic organ which is getting prolapsed? It's the uterus. So uterus is getting prolapsed from its place into the vagina or even out of the vagina into the external world. So to give you more idea, I will show you more videos so the concept will be more clear. But now see in this slide, these images are depicting that the uterus is exposing to the outside world, which should be called as pelvic organ prolapse. As definition says that, please concentrate, protrusion of the pelvic organs into the vaginal canal or even out of the vaginal canal should be called as prolapse. And how many types of prolapse are there, guys? It's a uterocervical prolapse and vaginal prolapse. In this video, in the beginning, I will be mainly discussing about the uterocervical prolapse. Later, I will be discussing about the vaginal prolapse. To make the concept more clear, now please watch this video. Guys, please first know where exactly the uterus is there. See here, this is the uterus, this is the bladder, and posteriorly you are going to have rectum. Now, please watch this video. The uterus, from its place, it's falling to the outside world. In the same video, you can also see that the urinary bladder, it is also falling posteriorly and it is also getting exposed. And even here, the rectum, it's also falling and even the rectum is also getting exposed to the outside world. So, here in this video, simultaneously, there is uterocervical prolapse. Anteriorly, there is cystocele. What does it mean by cystocele, guys? Cystocele is the protrusion of the bladder or herniation of the bladder from its side to the external world. So that is cystocele. Anteriorly it's present, and even posteriorly you can see rectocele is there. So please one more time watch this video, guys. Yeah, like this. Now, in this video, I will be showing more videos so that the concept will be clear. Now, guys, let me ask you one question. Why there is this prolapse? In a normal female, there is no prolapse. Why? Why? Because in a normal healthy female, the uterus have certain supports. What are those supports? Muscular supports are there, ligamentous supports are there, and even mechanical supports are there. Now, because of the presence of these supports, uterus is fixed in its place and it's not getting herniated or protruded into the vaginal canal or into the external world. So now, let's see those supports one by one. Guys, the first support I'm going to talk about, and the main support, is the muscular supports. What is that muscular support which is keeping the uterus in its place? The main support is the pelvic diaphragm, which is made up of levator ani muscles. Now this levator ani muscle, it's not a single muscle, but it's a group of two muscles. What are they? Pubococcygeus, iliococcygeus. See, this pubococcygeus and iliococcygeus, these two muscles, they are going to form the pelvic diaphragm, and this pelvic diaphragm is a major support for the uterus. Let me show you. Imagine that if this is the uterus is sitting on this pelvic diaphragm, something like this. Okay, so on the base, the uterus is supported by this pelvic diaphragm. Just imagine that if this pelvic diaphragm is getting weakened, what happens? The uterus simply protrudes out or falls down. That can lead to pelvic organ prolapse or uterocervical prolapse. Now, the question is, why these muscles gets weakened? See, you can see on my top that these muscles, okay, these muscles are nothing but the levator ani muscles and they are forming the pelvic diaphragm. Now, these muscles are innervated by, this is the MCQ, These muscles are innervated by the pudendal nerve. If there is any damage to this pudendal nerve, what happens? Now these muscles are no longer going to maintain their tone. If these muscles are no longer going to maintain their tone, they will become laxed, they will become very weakened, so that they will be no longer able to support the uterus. So what happens? The uterus simply protrudes out into the vaginal canal. So that can lead to pelvic organ prolapse or uterocervical prolapse. So this is the most common cause. So what is the most common cause for the uterocervical prolapse? The single most important cause is the damage to pudendal nerve. Okay. Now, after seeing this, let's discuss some more important muscles other than levator ani, which can support the uterus and even vagina. Guys, please concentrate in this image. The muscle which I am highlighting right now, okay, this red color muscle which I am highlighting right now, this is known as the levator ani muscle. We have already discussed that levator ani muscles are going to form the pelvic diaphragm, and levator ani muscles include what? Pubococcygeus and iliococcygeus, but not the ischiococcygeus. Important MCQ. Levator ani muscle which is forming the pelvic diaphragm is made up of pubococcygeus, iliococcygeus, but not the ischiococcygeus. Okay, important MCQ. Now, what you can see here, which I am highlighting right now, this is the pelvic diaphragm. Okay. Now, there is also one more diaphragm which is supporting the uterus. So, what is that? Can you see here, which I am highlighting right now in this area? See, this is nothing but the urogenital diaphragm. Okay. So, urogenital diaphragm also supports the uterus to keep the uterus in its place. Now, this urogenital diaphragm, it is made up of which muscles and which structures? This urogenital diaphragm is made up of a deep transverse perineal muscle. Okay, the muscle which you are seeing right now here, okay, which I am highlighting here, is nothing but the deep transverse perineal muscle. And this deep transverse perineal muscle superiorly covered by superior fascia, inferiorly covered by inferior fascia. This inferior fascia, okay, please concentrate here, this green color, okay, this green color lining, okay, so that green color lining is the inferior fascia, which is also known as a perineal membrane. Okay, please concentrate here. What is meant by perineal membrane? The inferior fascia of the urogenital diaphragm. Okay, so what I am trying to put into your mind, apart from pelvic diaphragm, there is also urogenital diaphragm, which is made up of deep transverse perineal muscle, superior fascia, inferior fascia, but also the external urethral sphincter, which I can't show you in this image, but as a part of urogenital diaphragm, there is also external urethral sphincter. So what I am trying to put into your mind, apart from pelvic diaphragm, urogenital diaphragm also supports the uterus. Okay, so that's a very important MCQ. Now, here most of the students will get confused. What is the superficial perineal pouch and deep perineal pouch? See, though superficial perineal pouch and deep perineal pouch is not relevant to pelvic organ prolapse, but here I want to take a moment and show you what exactly is superficial perineal pouch and deep perineal pouch. Okay, see, the space between the levator ani muscle, okay, here this is the levator ani muscle, and the urogenital diaphragm, superior fascia of the urogenital diaphragm. So whatever the space which you are seeing here, okay, this area, that is known as a deep perineal pouch. Okay, so deep perineal pouch or deep perineal space, it's a space between levator ani muscle and superior fascia of the urogenital diaphragm. What is superficial perineal pouch then? Superficial perineal pouch is the space between perineal membrane. So what is the perineal membrane, guys? Perineal membrane is nothing but the inferior fascia of the urogenital diaphragm. So between the inferior fascia and one more fascia is there known as the superficial fascia. Okay, this is superficial fascia, not the superior fascia. Superior fascia is something this. Now what I am talking is the superficial fascia. So between superficial fascia and perineal membrane or inferior fascia, whatever the space which is present over here, this space is known as superficial perineal pouch. Okay, so how many pouches are there, guys? Deep perineal pouch, this one deep perineal pouch, and the superficial perineal pouch. Why I am saying this, guys? Please concentrate that in the superficial perineal pouch here, the superficial perineal pouch, this blue color muscle which is present more axially, okay, more towards the midline. See, this midline structure will also support the uterus. So what is this muscle, guys? This is nothing but the bulbospongiosus muscle. So now if someone asks you, what are the structures which are supporting the uterus? The structures are the pelvic diaphragm, which is made up of the levator ani muscle, iliococcygeus, pubococcygeus. Okay, well and good. And also the urogenital diaphragm. Urogenital diaphragm is made up of deep transverse perineal muscle, external urethral sphincter, plus the superior fascia and inferior fascia. Okay, well and good. Now, apart from this, there is also a muscle known as the bulbospongiosus muscle, which is present in the superficial perineal pouch. Guys, now let me tell you one more muscle which is present in the superficial perineal pouch. See, here I can't show you, but let me ask you one question. In the deep perineal pouch, okay, here, deep perineal pouch. So, what exactly is the deep perineal pouch? Deep perineal pouch is the area between the perineal membrane and the levator ani muscle. So, here, in the deep perineal pouch, which muscle is there, guys? Just tell me. It is the deep transverse perineal muscle. Am I right or not? Yes. In the deep perineal pouch, there is deep transverse perineal muscle. Now, please answer me, in the superficial perineal pouch, which muscle will be there? Superficial transverse perineal muscle. So, superficial transverse perineal muscle and deep transverse perineal muscle, both of them will support the uterus. Okay, so please keep that point in mind. Now, please answer here, muscles which are supporting the uterus and vagina. There is a mnemonic which is blessed. So, which muscle, guys? It is bulbospongiosus, levator ani, which is made up of again two muscles. This E for external urethral sphincter as well as external anal sphincter. S for superficial transverse perineal muscle and D for deep transverse perineal muscle. So these are the structures which are going to support the uterus as well as vagina. Why I am saying this? Because you will be getting a question like all of the following muscles are going to support the uterus except. So you should know which muscles support the uterus and which muscles not. Please concentrate that ischio-coccygeus, okay, ischio-coccygeus is not a support for the uterus. Levator ani muscle, it's made up of only iliococcygeus and pubococcygeus but not ischio-coccygeus. Bulbospongiosus is going to support the uterus but not ischiocavernosus. Bulbospongiosus supports but not the ischiocavernosus. These are the very important MCQs which will be asked in the exam. Now, after seeing the muscular supports, let's go further. Now let's discuss about the mechanical supports. See, these are the mechanical structures which are supporting the uterus. What are they? The angle of anteversion and the angle of anteflexion. So what does I mean by angle of anteversion and anteflexion? See, even in the topic of anatomy, we have discussed that the vagina, cervix and uterus, okay, vagina, cervix and uterus, they are not simply lying longitudinally over one another. They are more of angulated, okay. If this is the vagina, the cervix and uterus, they are more angulated. There is angle between them, okay. So they are not simply longitudinal, something like this. They are angulated. So this angle is known as angle of anteversion and anteflexion. Now here let's take a minute and discuss what exactly is anteversion and anteflexion. Please concentrate, guys. Here in the vagina there is this a blue line going, that is the axis of the vagina. So the angle between the axis of vagina V and the axis of the cervix, this red line. So the cervical axis and the vaginal axis, they are making an acute angle of 90 degrees. So this is known as angle of anteversion, V. V for vagina and cervix. So the angle between vagina and cervix is angle of anteversion. So because of this 90-degree angle, the uterus is falling over onto the bladder. Okay, now you can clearly see here that the uterus is falling onto the bladder. It's not simply straight like this, it's falling onto the bladder. Now bladder is mechanically supporting the uterus, okay, so that uterus can't fall down. Okay, so the angle of anteversion doesn't allow the uterus to undergo prolapse. But what if the anteversion is lost and the uterus is become retroverted? Once the uterus is become retroverted, it can easily undergo prolapse. So retroversion of the uterus can lead to prolapse. Very important MCQ. Now the question is, why there is this angle of anteversion? Okay, we all know that uterus is having anteversion. Okay, there is this angle of anteversion and anteflexion. Okay, we all know that. Now why anteversion? Who is making this uterus to flex anteriorly? That answer will be given by the round ligament. Okay, so round ligaments are the structures which are pulling the uterus anteriorly. Okay, now let's discuss about the angle of anteflexion. I'm going to discuss more about the round ligaments like in the later parts of the same video, but for now let's discuss about the angle of anteflexion. See, what does it mean by angle of anteflexion? Simply, just like before, the angle between the axis of the cervix and the angle between the axis of a uterine body. So this angle, this obtuse angle of 120 degrees, this is known as angle of anteflexion. So there is angle of anteversion and angle of anteflexion which keeps the uterus to flex anteriorly and get a mechanical support from the bladder. Okay, now guys, please take some important points that retroversion of the uterus can lead to prolapse. Yes, we already know that. So what is that ligament which helps in anteversion? So which ligaments pulls the uterus forward anteriorly? It is a round ligament. Don't worry, I am going to show you the image. Now if someone asks you which ligament prevents the retroversion of the uterus will cause prolapse, but which ligament is preventing the retroversion? It's the uterosacral ligament, which are very important MCQs. Okay, now after this let's continue. Guys, please concentrate here. This is the uterus. Okay, what I am showing you, this is the uterus. Now the structures which are highlighted in green color, they are the round ligaments. So this is the anterior side and this is the posterior side. How can I know that? Here is the sacrum. Okay, this is the sacrum. This is the rectum, which you can see. This is the rectum. Now please concentrate. We all know that anterior to the uterus, which structures are present? This is the bladder. Now these round ligaments which are highlighted in green color, they are going something like this, anteriorly. If they are going anteriorly, see, on one side they are attached to the uterus, on the other side they are getting attached to the anteriorly. Okay, anteriorly they are going to attach onto the labia majora. So now they are pulling the uterus anteriorly so that the uterus will become anteverted. So the angle of anteversion is maintained by round ligaments. Even you can see here in this image, see, this is the uterus. Now as we have already discussed that the uterus is falling onto the bladder anteverted. These ligaments, if you can see, these ligaments which are moving anteriorly, something like this, they are pulling the uterus towards the anterior side. Round ligaments maintain the anteversion. Okay, well and good. Now let's see some important points. Ligaments which keeps the uterus anteverted and anteflexed. Answer is round ligament. Anteflexion is maintained by round ligament. Now ligaments preventing the retroversion of the uterus, we have already discussed. What is that? It is uterosacral ligament. Okay, well and good. Now guys, here in this image I just want to discuss more about a few ligaments. Guys, please concentrate. These ligaments which are coming posteriorly, okay, which are coming like towards the uterus, and they are getting attached onto the sacrum. So these ligaments are known as the uterosacral ligaments, from the uterus to the sacrum. Uterosacral ligaments. Now here, this ligament, the fan shaped ligament, like from the uterus, and they are going sides to the bones, okay, to the pelvis. So these ligaments which are attached on one side to the uterus and other side to the pelvic bone, these are known as the transverse ligaments. These transverse ligaments are also known as cardinal ligaments. They are also known as McEnroth ligament. Three names, same ligament. So McEnroth's ligament, cardinal ligament and transverse ligament, they are one and the same. Now anteriorly you are going to have one more ligament, okay, this ligament. So this ligament is known as pubocervical ligament, okay, pubocervical ligament. So one side it's the pubis and the other side it's getting attached to the cervix. So how many ligaments are there? There are three main ligamentous supports. These are the main ligamentous supports. See, I have discussed about the round ligament, but round ligament is not the main primary support. Round ligament maintains the anteversion, true, but round ligament is a secondary support. So what are the three main ligamentous supports, guys? The three main ligamentous supports which you need to know are the pubocervical ligament, the transverse ligament or McEnroth's ligament, and the uterosacral ligament. These three ligaments together known as triradiate ligaments, okay, triradiate ligaments. Now out of all these triradiate ligaments, the question is, which is the most powerful ligament, the main support, main ligamentous support? Out of all this, the main ligamentous supports is McEnroth's ligament or cardinal ligament or the transverse ligament. So these are a very important MCQs. Now let's discuss about the ligamentous supports. Now guys, the important point to be noted is the triradiate ligaments are the main primary supports, are the main primary ligamentous supports. See, out of overall most important support for the uterus is a muscular support, there is no doubt. But which ligaments mainly support the uterus? Triradiate ligaments. After triradiate ligament, even round ligament can support, but that's a secondary support. Have I ever said that the broad ligament, is it going to support the uterus to be in its place? No. Broad ligament, it's a peritoneal fold. Okay, it's not going to support the uterus. Okay, please, important point is broad ligament and round ligament, they are not the true supports. They are not the primary supports. Even round ligament is considered as a secondary support, but broad ligament is not a support at all. This is a very, very important MCQ you have to keep in mind. Now, after this, let's continue further. Guys, please concentrate. What are the primary supports? Already we have discussed. Pubocervical ligament, cardinal ligament or McEnroth's ligament, uterocervical ligament. See, a round ligament is a secondary support. Okay, it's not a primary support. Primary supports are the triradiate ligaments. Okay. Now, which ligament is not a support at all? It's a broad ligament. Broad ligament is a peritoneal. It's a covering. Okay, it doesn't support uterus at all. Okay. Now, after this, let's see what are the important risk factors which are leading to uterine prolapse or the uterocervical prolapse. Now, please concentrate that we have already discussed that trauma to the pudendal nerve. Okay, trauma to the pudendal nerve is the most important cause for the uterocervical prolapse we have seen. Now, the question is, what are the other important risk factors or why the pudendal nerve is getting damaged? Now, let's discuss. Now, let's start from here. The traumatic deliveries or birth trauma. See, there is any trauma during the delivery that can cause the prolapse. Why? See, most of the time the prolapse will be seen after the delivery. Why? The question is because of the faulty instrumentation. See, if the obstetrician is applying the vacuum or the forceps inappropriately, for example, a forceps should be applied in order to take out the baby if the cervix is fully dilated. When the cervix is fully dilated, then that's the moment you have to apply the forceps if there is a prolonged second stage of labor. Okay, let me make it more simple. There is prolonged second stage of labor. Now the baby is not coming out. Then you have to apply the forceps. Okay, it's okay. But in order to apply the forceps, there should be total cervical dilation. 10 centimeter cervical dilation should be there. If there is only 6 centimeter dilation, or if there is only 7 centimeter dilation, now if you are applying the forceps, this forceps can cause a damage to the cervix. It can cause cervical lacerations, or inadvertent application of this forceps can cause tears in the ligaments. So whenever the ligaments are teared, you are simply taking out the ligamentous support for the uterus. So the uterus can fall after the delivery. So this is what can happen. Or if you are using this vacuum or forceps inadvertently or inappropriately, that can damage the pudendal nerve. So whenever the pudendal nerve is damaged, that will decrease the tone to the pelvic diaphragm. So whenever you are taking out the tone from the pelvic diaphragm, that uterus can simply fall out. So traumatic deliveries because of faulty instrumentation, and that will lead to pudendal nerve damage, or if there is a ligamentous tears because of inappropriate use of this vacuum or forceps, that can lead to genital prolapse. True. Repeated childbirths. What happens if there is repeated childbirth or multiparity? More number of deliveries, more the muscles will get weakened. Okay, see, a baby is pushing, during normal vaginal delivery, baby is pushing against the pelvic diaphragm. Am I right or not? Yes. So in that process, these muscles get too much fatigue. Too many deliveries, too much fatigue. They will become more lax. They will become less toned. So that will take out the muscular support from the uterus, and that may lead to uterine prolapse. True. Precipitate labor. What does it mean? What does I mean by precipitate labor? Very fast labor. Okay, the labor is getting completed in a very short time. So whenever there is a precipitate labor, the muscles are getting too much contracted. They might get cramped or getting fatigued. So that will take out the muscular support. Why? Because the muscles are getting fatigued. So whenever they are fatigued, they lost their tone. So simply uterus can fall down now. In the same way, prolonged labor, especially prolonged second stage of labor. What does I mean by prolonged labor? The second stage of labor is getting more than 2 hours in a nulliparous, or getting more than 1 hour in a multiparous female. If there is too much amount of time, if it's taking too much amount of time, baby is getting stuck over there. Baby's head is getting compressed against the pelvic diaphragm. So whenever the baby's head is getting compressed against the pelvic diaphragm, what happens? Because of this mechanical pressure, what happens? The blood supply to this pelvic diaphragm is getting compromised. Or if the baby's head is getting compressed against the pelvic diaphragm, even this will decrease the blood flow to the pudendal nerve. So there is ischemia getting developed in this area. So whenever there is ischemia, they will become fatigue, or there will be damage to the pudendal nerve. So this will decrease the tone of these pelvic structures or the pelvic diaphragm, and that can lead to prolapse. True. Now, certain conditions like Marfan syndrome, Ehlers-Danlos syndrome, see, these are connective tissue disorders. Now here in the Marfan syndrome, we all know that there is a fibrillin defect, fibrillin gene defect. Now, because of this Marfan syndrome or Ehlers-Danlos syndrome, the connective tissue is not properly formed. We all know that connective tissue is a part of muscles. Connective tissue is a part of ligaments. So whenever there is a connective tissue defects, the pelvic diaphragm is not properly made, or the ligamentous supports are not properly made. So whenever the muscular diaphragm is not properly made, it is not able to hold the uterus properly in its place, or the ligaments are not tight enough to hold the uterus in its place. That can lead to protrusion of uterus from its place to the outside world. So that can lead to prolapse, or heavy lift bearing after the delivery. For example, or early resumption of work after delivery. Now what does I mean by? There is a female, she just have delivered 2 days back, and now she is back into her work. She is doing her household work. So she is lifting heavy weights. Lifting these heavy weights increases the intra-abdominal pressure. Why? Because still this uterus is an abdominal organ. Now, because of the increased intra-abdominal pressure, this pressure will kick the uterus down. So that can lead to prolapse. So, early resumption of work or heavy lift bearing or the conditions which are associated with the increased intra-abdominal pressure like heavy weight bearing or severe cough, ascites or constipation, all this will increase the intra-abdominal pressure that will push the uterus down and that can lead to prolapse. Now let's talk about the spina bifida. We all know that spina bifida is due to non-closure of the posterior neural pore. Now if a female is having this spina bifida, then there will be decrease in neuronal tone to the pelvic diaphragm. Okay, the neuronal supply, the neuronal innervation to her pelvic diaphragm is not that good. So her pelvic diaphragm is not tight enough to hold the uterus. So what happens? Now that can simply lead to prolapse. So all these are the conditions in a female which can lead to prolapse. Now after seeing these risk factors, let's continue. Now let's see the clinical symptoms. Now just please think logically and say, if the uterus, if it is coming into the vaginal canal or even if it's coming outside world, now what the patient feels? The patient will feel like there is some dragging sensation in her vagina and the patient will feel that something is coming out of her vagina. So the most common symptom what a patient feel with the genital prolapse is something coming out of the vagina or the dragging sensation. Okay, well and good. Now, because of the prolapse, please understood, the uterus is supported by pubocervical ligaments, transverse ligaments and uterosacral ligaments. All these ligaments are holding the uterus in its place. But whenever there is a prolapse, these ligaments are also getting stretched. Okay, these ligaments along with the prolapsed uterus, they are stretched down. So what happens? The stretching of these ligaments, especially uterosacral ligaments, will cause a groin or back pain in this female. So female will say that she is having this groin pain or back pain, and she will also say that something is coming out of my vagina. Now, there will be difficult urinating and defecating. Why there is difficult urinating and defecation, guys? Why? Because see, most of the time that this uterocervical prolapse is associated with the cystocele anteriorly. So whenever there is a cystocele, that's a prolapsing of the bladder. So whenever the urinary bladder is prolapsed, do you think that there will be a normal micturition? No, there will be difficult micturition. So there will be difficulty in urinating as well as difficulty in defecating. Why? Because there is rectocele, maybe associated with the rectocele posteriorly. Okay, now there is increased risk of a UTI. Why there is increased risk of UTI? Why? Because there is urinary retention because of the cystocele. That can lead to urinary infections or even stone formation, nephrolithiasis. Okay, so because of the hydroureters, hydronephrosis, there will be stone formation, there will be urinary tract infections in this female. True. And that because of the urinary tract infection, the female can even have the leukocytosis and fever also. Now, so what about this decubitus ulcer? Okay, very important MCQ for the exam. Guys, please concentrate. Here on the top of my head, you are seeing an image where you can see ulcers which are getting developed over the uterus. So these ulcers are known as the decubitus ulcer. What exactly is a decubitus ulcer? This decubitus ulcer is because of the venous congestion. See, whenever the uterus it's getting prolapsed outside, do you think that there will be a proper blood supply to it? No, the blood supply is compromised. Okay, so the blood is getting accumulated in the tissue. There is a venous congestion. Now, when the uterus is falling down, because of the friction, now the uterus is present between the two thighs. Now because of the friction, there may be development of a small ulcer. And now this ulcer is not getting healed. Why it's not getting healed? Because there is no proper blood supply. Because of the venous congestion, now these ulcers which are because of the friction, they are known as decubitus ulcer. Main MCQ is decubitus ulcer is because of the venous congestion. Okay, this is the MCQ. Now, so how we can treat this decubitus ulcer? That main treatment is reposition. Okay. See, this is not the management of the genital prolapse or the uterine prolapse. See, reposition, simply reposition and giving this actreflavin and glycerin is not the management option for the uterocervical prolapse. See, reposition, after reposition, you are going to completely pack the uterine cavity with the actreflavin and glycerin. See, this is the treatment which you are going to do to treat the decubitus ulcer because of the venous congestion. Okay, so this is not the management for the whole uterocervical prolapse. Okay, now let's discuss about congenital prolapse. What does I mean by congenital prolapse? The name itself, it's very clear, congenital. Because of certain congenital reasons, there is prolapse. Please concentrate, guys. Usually prolapse is something seen in older ages. Okay, please concentrate here. Because of menopause, the pelvic diaphragm got weakened and the pelvic diaphragm got less tone, so that it is no longer able to support the uterus. So menopause is an important reason. It's one of the important reason for the uterine prolapse. But why a female who is very young can have a prolapse? Even the prolapse can be seen in a 10-year-old or 15-year-old. Usually prolapse is something seen in older age women, or prolapse is something seen after the delivery. Why prolapse is happening in a female who is very young? Because of certain congenital reasons where the connective tissues are not properly developed, or for example like in spina bifida where the neuronal tone is not properly maintained. So what exactly is congenital prolapse? A prolapse seen in very young females, young nulliparous females. She haven't even delivered, but there is prolapse because of certain connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome, spina bifida, osteogenesis imperfecta. Okay, so in these conditions, if a female is having uterine prolapse means, then we are going to call it as congenital prolapse. Now from here we are going to discuss about the management for the genital prolapse. Let's start the management, guys. For example, if there is this congenital prolapse in a young female, a nulliparous female, there is prolapse. Now, does she want to have her future pregnancy or not? Definitely she want to have her future pregnancy. Or there is this young female who is not having congenital prolapse, but she is a young female. She want to have a future pregnancy. Now, in this group, if there is prolapse means, how we are going to manage? Congenital prolapse and a young female who is desiring the future pregnancy. Now here, in the reproductive age group women, we are going to mainly perform two types of surgeries. In a young reproductive age group women, two surgeries are advised. What are they? Sling surgery is one, followed by Fothergill-Manchester surgery. Okay, now first let's discuss about the sling surgery. See, if there is this congenital prolapse, the management is sling surgery. Okay, so what exactly is this sling? Sling is nothing but the material which we are using as a sling in this condition is merceline tape. Okay, here what you are seeing is a merceline tape. It's a synthetic compound. Now what exactly is this merceline tape? Merceline tape is nothing but a mechanical device or a mechanical structure which is a flexible. It's just like a strap or a belt which is used. Okay, this strap is used to hold the uterus. Okay, already uterus is prolapsed. Okay, uterus, let me show you. Uterus is prolapsed outside. So now what I have to do? I have to support this uterus. How I can support this uterus? I will use this sling. Okay, imagine that this is a sling. I am going to use this sling and I am going to keep the uterus in its place, something like this. So simply I can say that I am using the slings as ligaments. Okay, so I am just recreating the ligaments by using these slings so that the uterus will stay in its place. Okay, so this is the treatment of option which I will be doing in a female who is going to have a congenital prolapse or a young female of reproductive age who is desiring the future pregnancy. So what is that synthetic material I am going to use? It's a merceline tape. Now, sling surgery. See, if this is the uterus, okay, this is the uterus. Now I can use an anterior sling or I can use the posterior sling. Okay, imagine that this is the anterior sling and this is the posterior sling. See, there are two types of slings available. Anterior sling examples. Okay, one is Purandare sling, okay, Purandare sling and Kanna sling. Okay, so examples of anterior sling are Purandare sling and Kanna sling. So what exactly I mean by anterior sling? Which means the sling on one side is attached to the uterus, on the other side the sling is getting attached anteriorly so that it is going to support the uterus. What does I mean by posterior sling? Posterior sling means on one side sling is getting attached to the uterus, on the other side the sling is getting attached posteriorly to the abdominal wall. Now we will discuss where exactly they are getting attached, don't worry. Now please concentrate here that the examples of anterior sling are Purandare sling and Kanna sling. See, this Purandare sling is an example of anterior sling, right? So it is getting attached anteriorly to the rectus fascia. Okay, we are going to have the six-pack muscle, right? That rectus sheath. So the Purandare sling on one side it's getting attached to the uterus, on the other side it is getting attached to the rectus fascia. And this Kanna sling, even it's an example of anterior sling. So on one side it is getting attached to the uterus, on the other side it is getting attached to the anterior superior iliac spine. Means it is attaching to the bone. Okay, single point. Now, what are the examples of posterior sling? Examples of posterior sling are Shirodkar sling. Now, on one side this Shirodkar sling is getting attached to the uterus, on the other side this Shirodkar sling is getting attached to the sacrum posteriorly. Okay, now let's see some important MCQs. Guys, let's talk about the Kanna sling first. Kanna sling is associated with osteitis. Why? Because Kanna sling anteriorly it is getting attached to the anterior superior iliac spine. So this can cause inflammation of that point leading to osteitis. True. Now let's talk about the Purandare sling. Purandare sling, it's an anterior sling. It's an example of a dynamic sling. Dynamic means it's a movement, it can move. What does that mean by exactly? See, rectus fascia, is it a single point? Is it a single point or not? No, it's not a single point. It's a fascia. It's a very large structure. So anywhere over that fascia, you can attach this sling. So it's not a one single point. So Purandare sling is an example of a dynamic sling. It can be attached anywhere over the rectus fascia. But Kanna sling, where it is getting attached? It is getting attached over the anterior superior iliac spine. Anterior superior iliac spine is a single point. So it's an example of a static sling. Yes. Now, anterior sling surgeries are very much like, having less complications, but the success rate is a bit less. Now, after discussing the anterior slings, now let's discuss a few more important points about the posterior sling. So what exactly is the posterior sling, guys? It is the Shirodkar sling. Posteriorly, it's getting attached onto the sacrum. Now let's discuss some important points. Now, Shirodkar sling, it's an example of posterior sling. Okay, it's a static sling. It's not a dynamic sling. It's a static sling. Why it is a static sling? Why? Because see here, this is the uterus. Okay, imagine that this is the uterus or cervix. Now here the sling on one side is getting attached to the uterus and it is traveling posteriorly. Please concentrate. It is traveling posteriorly and it is getting sutured over the sacral promontory. Am I right or not? Yes, on one side it's the uterus. On the posterior side it is getting attached onto a single point, which is the sacral promontory. So it's a single point, so it's a static sling. Okay, it's not a dynamic sling, it's a static sling. Now one side it's the uterus, isthmus of the uterus, and the other side it's getting attached over the sacral promontory. Now please think logically. Out of all the triradiate ligament, pubocervical, transverse ligament and uterosacral ligament. Uterosacral ligament means on one side the ligaments are getting attached to the uterus, on the other side the ligaments are getting attached to the sacrum. So uterosacral ligament. Okay, uterosacral ligament. Now this sling, this Shirodkar sling, it mimics the uterosacral ligament. Am I right or not? Yes. Why? Because even this sling, on one side it is getting attached to the uterus, isthmus of the uterus, on the other side it is getting attached to the sacrum. So uterosacral ligament. So all these are the important points about the Shirodkar sling. Okay, guys, please concentrate that anterior sling surgeries have less complications. We have already seen. Please concentrate here. Anterior sling surgeries have less complications, but also success rate is less. But if I am talking about the posterior sling, which is the Shirodkar sling, it is having more complications. What are the more complications? Guys, please concentrate in this image. When this sling is coming on the left side, okay, when the sling is coming on the left side, there is a structure, this green color structure. What is this green color structure? This is the genitofemoral nerve. See, when the Mercellin tape, when it's coming posteriorly, especially on the left side, this genitofemoral nerve can be damaged. Okay, and especially on the left side, there is one structure which is depicted as C. What is this structure? This is sigmoid colon, and this sigmoid colon may get obstructed because of the sling. So the posterior sling surgeries have more complications, and especially on which side, guys? Especially on the left side. So what are the complications? There can be obstruction of the sigmoid colon, or there can be damage to the genitofemoral nerves, or even the mesenteric vessels can be damaged, and there can be a ureteric injury. So posterior sling surgeries, more complications, especially on the left side. And what are the complications, guys? The main complications are the obstruction to the sigmoid colon, damage to the genitofemoral nerve, or the mesenteric vessels, or there can be ureteric damage. Okay, guys, we have seen the anterior sling surgeries, okay, which are something like this. A sling is getting attached on one side to the uterus, on other side to the anteriorly, either onto the rectus fascia or onto the anterior superior iliac spine. We have seen. We have also seen the posterior sling surgeries. Complications are seen with the posterior sling surgeries. We have seen. So, in order to take out the complications because of posterior sling surgeries, now we are going to have a hybrid sling. So, what is this hybrid sling? Guys, please answer my question. Complication with the posterior sling are seen on which side? Left side. So, avoid posterior sling surgery on the left side. So, have a posterior sling surgery on a right side. Okay, have a posterior sling surgery on a right side. And on the left side, have an anterior sling surgery, that is the Purandare sling. So, what is this hybrid sling? Hybrid sling is also known as a Virkud sling. So what exactly is this Virkud sling? This Virkud sling main purpose is to take out the complications of the posterior sling surgery, especially on the left side. So we are going to have a hybrid sling where on the left side we are going to have a anterior sling. On the right side we are going to place a posterior sling. So please concentrate in this image, guys. In this image, on the left side, which type of sling is there? It's a Purandare sling. Okay, it's a Purandare sling, anterior sling. And on the right side, see, we are going to have a posterior sling, which is a Shirodkar sling. So this is known as a composite sling or Virkud sling. Okay, so this is a very, very important. On the right side, there is Shirodkar sling. On the left side, there is Purandare sling. Now, guys, please concentrate, okay, on the management of prolapse. Okay, we are continuing the management of prolapse. See, so far the sling surgery is completed. We have seen that the sling surgery is the main option, especially for the congenital prolapse or the prolapse in a young female who is desiring the pregnancy. Now, I just want to say one important MCQ here. Okay, so please take that. See, in order to perform this sling surgery, which is also known as cervicopexy, in order to perform the sling surgery, uterocervical length. We all know that there is a ratio between the uterus and cervix. We have already discussed this in the part of anatomy. The uterocervical length should be normal. If you want to perform this sling surgery, then the uterocervical length should be normal. Now, let's continue further. Guys, there is a female, young female, who is not desiring any future child. Okay. Now, there is a female and she don't want to have any future child. She doesn't want. Now, she want to have to continue her menstrual cycle. See, there is this young female who don't want to have any of her future pregnancy, but she want to continue her menstrual cycle. So now what is the treatment of choice? Should you have to do sling surgery in this female? No. Sling surgery is done in a female who is desiring the pregnancy. Now in this type of females, then the best management will be Fothergill's or Manchester surgery. Now in this Fothergill's or Manchester repair, what exactly is being done? We are going to do, there are two steps. The first step is we are going to do cervical amputation. Okay, see, let me show you here that this is the uterus, okay, and this is the vagina. Okay, so this part is what? This is the cervix. We all know that is the cervix, especially that is the portio vaginalis towards the cervix. Now what we are going to do is we are going to just simply chop out this cervix. That is the cervical amputation is the first step. Now if you just chop out this cervix, there will be formation of lots of adhesions in this area. Okay, there will be formation of lots of adhesions. Now these adhesions are going to create a mechanical barrier. Okay, just reposition the uterus. If there is a prolapsed uterus, reposition the uterus, just chop out the cervix. If you chop out the cervix, there will be formation of lots of adhesions, and these adhesions now going to give the mechanical support so that this uterus is not going to fall down back. So this is the first step. Along with the cervical amputation, there is a second step which is known as a plication of the cardinal ligament or the McEnroth's ligament. These two are the main important steps. Cervical amputation along with the plication of the cardinal ligament. What exactly is this plication of the cardinal ligament? Guys, please understand that if this is the uterus, I am just showing you from the lateral view. See, posteriorly a very strong ligament is there. What is that? Uterosacral ligament. Transversely, a very strong, powerful ligament out of all the triradiate ligaments. What is that? The transverse ligament is there. See, posteriorly there is very good support. That is the uterosacral ligament. And sideways, there are these transverse ligaments or McEnroth's ligaments are there. Okay, these are also well and good. But anteriorly, the pubocervical ligaments, they are not the toughest ligaments. They are not as strong as the cardinal ligaments or the uterosacral ligaments. So now what we are going to do? Posteriorly, there is very good support. But anteriorly, there is not that much support. So what we are going to do? We are going to take this transverse ligaments or cardinal ligaments and we are going to plicate these ligaments anteriorly. We are going to take these ligaments and attach these ligaments anteriorly. So that anteriorly now there are these transverse ligaments or cardinal ligaments. Posteriorly, now we have this uterosacral ligaments. So from both the sides, there is a very powerful ligamentous support. So this is what is being done in the second step of the Fothergill's Manchester surgery. So the first step is cervical amputation, creating the adhesions, and those adhesions are creating a mechanical barrier so that the uterus is not falling down. And the second step is the plication of the cardinal or McEnroth's ligament. Okay, taking those McEnroth's ligaments from the transverse side and we are taking and attaching them anteriorly. Okay, so this is the second step. Guys, important point is this cervical amputation is not good as you think. Why? Because this can lead to second trimester recurrent abortions. First of all, our lady, this female, she doesn't want to have any future child. Who knows? If she changes her mind and in the future she is desiring the pregnancy. Now you have already amputated her cervix. Now that can cause second trimester recurrent abortions because of cervical incompetence. Why? Because she lost her cervix. Now if she get pregnancy, then simply the cervix can dilate. That is the cervical incompetence. So that can lead to second trimester recurrent abortions. Or you have chopped out the cervix, then because of too much amount of healing or too much amount of the scar formation, there can be cervical stenosis. Okay, that cervical stenosis doesn't allow the menstrual blood to come out. So all these are the complications because of the cervical amputation. So this is not as good as you think. So now what we are doing is we are taking out the cervical amputation. We are only doing the plication of the cardinal ligament. Then this should be called as Schrodinger's modification of Fothergill's repair. See, please concentrate. Fothergill's repair or Fothergill's surgery includes both. Fothergill's Manchester repair includes both cervical amputation and plication of the cardinal ligaments. But out of these two, which is not good? Cervical amputation is not good. So if you don't perform cervical amputation, if you only perform plication of the cardinal ligament, then that should be called as Schrodinger's modification of Fothergill's repair, where only plication of the cardinal ligaments is performed, cervical amputation is not performed. Is it going to be good? Yes, better than the Fothergill's Manchester repair. Why? Because there is no complication of cervical stenosis, there is no complication of second trimester recurrent abortions, there is no complication of that, a cervical incompetence. If she want to have a future child, there won't be any complications. Okay, so Schrodinger's modification of Fothergill's repair is a surgery where you are not performing the cervical amputation. Okay, now let's go further, guys. Now we are discussing the management of uterine prolapse in a reproductive age group woman. See, in a reproductive age group woman, you can perform two types of surgeries. What are they? Either you can perform a sling surgery, or either you can perform a Fothergill's Manchester repair. You can perform two types of surgeries. But when to perform sling surgery and when to perform a Fothergill's Manchester repair, it depends on whether she is desiring her future pregnancy, and it also depends on her uterocervical length. Please concentrate. There is this young female, 15-year-old or 10-year-old. Does she desire future pregnancy or not? Definitely she will desire future pregnancy. Why? Because she is not pregnant at all since. Okay. Till now she is not pregnant. She is very young. Definitely she want to have babies in her future. So now in a young, if there is a prolapse, definitely you are going to call it as a congenital prolapse. What about the status of the future pregnancy? It is desired, yes. And what about the uterocervical length? If uterocervical length is the normal, then what type of surgery I am going to do? I am going for the sling surgery. Okay. Now there is this reproductive age group woman, and she is also desiring her future pregnancy. She is nulliparous, or maybe she is not nulliparous, but she want to have her a pregnancy in the future, and her uterocervical length is also normal. Now what is the management? Again sling surgery. Okay, now there is this reproductive age group woman, and she doesn't want to have any future pregnancy, and also guys, please remember that her uterocervical length is increased. Guys, the moment uterocervical length is increased, you are not going to do sling surgery. Then what you are going to do? If the uterocervical length is increased, you are going to chop out that extra length of the cervix. So what is that? It is Fothergill's. Let me show you. It is Fothergill's Manchester. Fothergill's or Manchester repair. Okay. Now there is this reproductive age group woman. She is desiring her future pregnancy. Yes, reproductive age. She want to have a future pregnancy. Usually what we will do? We will do sling surgery. But see, her uterocervical length is increased. If her uterocervical length is increased, are you going to do a sling surgery? No. Usually reproductive age and future pregnancy is desired. What you have to do? You have to do a sling surgery. But once uterocervical length is increased, the sling surgery is not able, you are not going to do the sling surgery. What you have to do is again Fothergill's or Manchester repair should be done. Okay, so this is what you have to know, and this is the place definitely where you are going to get your MCQs. Okay, now let's go further. Now there is this elderly female. This is a separate question. Okay, this is a separate case. Reproductive age group woman completed. Now we are going to jump into an area where our woman is a elderly female. This is elder female, and definitely if she is elder, 45 years or 50 years, definitely she don't want to have any future pregnancy, or she don't want to have any her menstrual function. No pregnancy, no menstrual function. She is almost elderly female. Now she is having this prolapse. Okay, her uterus is hanging out. What you can do? The best you can do is hysterectomy. She is elderly female, so you can, without any doubt, you can go for the vaginal hysterectomy. What exactly is this vaginal hysterectomy? Here you are going to do a vaginal hysterectomy. Okay, via vaginal route you are going to take out that uterus. Along with the vaginal hysterectomy, you are going to do the pelvic floor repair. Okay, it's a part of vaginal hysterectomy. Along with that, plus or minus, you can or you cannot. Okay, totally depends on you. Okay, you can do sacrospinous colpopexy. Okay, we are going to discuss what exactly is the sacrospinous colpopexy in a minute. But please remember, there is this elderly female who don't want to have any future pregnancy, or who don't want to continue her menstrual cycle. Then what you can simply do, our best possible management is hysterectomy, hysterectomy, vaginal hysterectomy, along with the pelvic floor repair, plus or minus sacrospinous colpopexy. Now let's discuss about one more case. Same elderly female. There is the same elderly female. Now this female, okay, please concentrate here. Okay, just wait guys, let's don't talk about the elderly female now. Right now don't talk about the elderly female. Just for a minute, let's think about, there is this female who is very young. Normally young females are reproductive age group women. What we are going to do? We are going to perform sling surgery, or we are going to perform Fothergill's Manchester repair. These are the two options which are available. Now there is our female who is young, but there are certain contraindications for her surgery, or she is not she is not willing to go for the surgery. Okay, she is refusing, or there are certain contraindications for the surgery. She is having too much amount of hypertension, diabetes, whatsoever. She is having certain cardiac diseases. Now in this female, we are not going to do the sling surgery, or not we are going to do the Fothergill's Manchester repair. Here what we can do is ring pessary. Okay, at the level of ischial spines, we are going to put a mechanical device. Okay, a mechanical device we are going to keep at the level of ischial spines, and this mechanical device is going to support the falling uterus till the time, please remember guys, till the time this mechanical device is in its place, it won't allow the uterus to fall down. Don't worry, I will show you a video so that the concept will be clear. Till the time this mechanical device is in its place, the uterine prolapse will be stopped. But is it going to be a permanent cure? No, this is not a permanent cure, just like a surgery. It is temporary. And you know, usually these pessaries, okay, this ring pessary or donut pessary or gel horn pessary, there are different types. See, for example, this is a donut pessary. This is called as a donut pessary. This is a gel horn. Okay, gel horn pessary. See, these pessaries, they are a temporary. Okay, now these pessaries should be removed on a regular basis. They should be changed. If you fail to do so, that can lead to vesicovaginal fistulas. If you keep them in a place constantly, that can cause ischemia in that region. That can lead to vesicovaginal fistulas. Okay, now what we are discussing, female, young female, contraindication or refusing. What you can do? You have to go with the pessary. Now please concentrate on this image. Okay, it's a video. Please concentrate that uterus is falling down. This is the uterine prolapse. What you are seeing is a gel horn pessary. Okay, so on one end you have applied the gel and you are keeping it in the introitus. Now you are taking this gel horn pessary. See, this gel horn pessary is repositioning the uterus to its place. It's a mechanical support and it is also temporary. Important MCQ. Now, what the other places where you can use these type of pessaries? Not only in a young who is refusing or having contraindications, but these type of pessaries can also be used during pregnancy. See, there is a pregnant female and now there is this prolapse happened. Prolapse during pregnancy. What you have to do? You have to use the ring pessary, or there is prolapse during puerperium after delivery. Okay, just after delivery, the time period is a puerperium, right? Now, during puerperium, if there is this prolapse, what you are going to do? The management is done with the ring pessary. Or, please concentrate, guys. Again, I am going to repeat this point in the next slide, but please concentrate. There is this old female with a contraindication to anesthesia. There is this old female. Now she is having certain contraindication to surgery, and she is also having certain contraindication to anesthesia also. You are not supposed to give anesthesia at all. Now in these conditions, you can use this ring pessary. Okay. Now please concentrate on this slide. See, now our female is an old female. Okay. In the before slide, our female is a young female. Young female, contraindication to surgery or refusing. Ring pessary, okay. But now our female is a old female. She is having certain contraindications to the surgery, or if she is refusing. Now what we can do? We can do a simple type of surgery which is known as liphocolpoclysis. It's not even a big surgery. It's not a major surgery. It's very simple. What we are going to do here? See, colpoclysis means, colpo means vagina, clysis means closure. Colpoclysis means, see, if this is the vagina, okay, it's a fibromuscular tube. Now, we are going to scrape, okay, we are going to scrape the walls of the vagina. See, when you are doing this mechanical abrasion, okay, this mechanical abrasion can create lots of adhesions. So, there will be lots and lots of adhesions which are getting developed in this fibromuscular canal of the vagina. So that because of these adhesions, there will be mechanical support so that uterus won't fall down. Okay. Now please concentrate that this is the uterus. Okay. Now this is the vagina. What we have done, we have created adhesions over here. We have created adhesions something like this because of the scraping. Now these adhesions, do you think logically these adhesions will allow the uterus to fall down? No, they are now acting as a mechanical barrier. So this is liphocolpoclysis, which should be done only in a old females. This liphocolpoclysis should never be done. It's contraindicated in young or reproductive females. Why? Because you are totally closing, you are totally occluding the vagina. If you have done so, the coital function is going to be impaired. How can she have her sex? Or if you have totally closed her vagina, how can she have her menses? So liphocolpoclysis is only done in old females more than 65 years of age. And that too, this colpoclysis is done for those females who are having contraindication to surgery. Okay. Now, why I am saying like that? If she is an old female, elderly female, what we have to do ideally? We have to do ward myohysterectomy. If she is having a contraindication for that ward myohysterectomy, then we have to go with the liphocolpoclysis. Now, please concentrate. Again, I am repeating. Already I have said this in the before slide, but now I am repeating. See, there is this old female. She is having contraindication to the surgery. Okay. Usually, if she have contraindication to surgery or if she is refusing, what we will do? Liphocolpoclysis we will do. Even please concentrate, for performing this scraping of the vagina, liphocolpoclysis, it's a painful procedure, right? We are scraping. It needs anesthesia. But our female is having contraindication for surgery or she is refusing. So, she is not going for the liphocolpoclysis. Okay, well and good. Also, she is having contraindication to anesthesia. So, if she is having contraindication to anesthesia, you are not supposed to do liphocolpoclysis also. Why? Because liphocolpoclysis needs anesthesia. So, old female, contraindication to anesthesia. Now, what we can do is the ring pessary. So, in the before slide, I have said ring pessary. It's an option during puerperium. It's an option for the genital prolapse during puerperium, during pregnancy, or old female who is refusing the surgery or contraindication to the surgery and also having contraindication to the anesthesia. So now even here you can use the ring pessary. Okay. Now let's discuss about walled prolapse. What exactly I mean by walled prolapse, guys? Please remember that This is the vagina. Okay. Imagine that this is a vagina, which is a fibromuscular tube. Here what will be there? Here there will be uterus. Okay, something like this. Okay, uterus and cervix. Now, a female, because of whatever might be the reason, she have undergone hysterectomy. Means you have removed her uterus and cervix. Okay, hysterectomy is performed. Now, this vault, okay, the stump of the vagina, okay, this area is sutured something like this. Now, this is called as a vaginal vault. Now, even this vaginal vault can be prolapsed out. Okay, simply this vaginal vault can simply prolapse out. So that's what is known as vault prolapse, especially seen in those females who have undergone hysterectomy. Now, what we have to do? See, vault is prolapsed. So what do you have to do? You have to suspend this vault, or you have to suture the vault to certain other surrounding structures, something like ligaments. Now please concentrate. For vault prolapse, which type of suspension surgeries we are doing? So what are they? Mesh sacral colpopexy can be performed, or uterosacral suspension, or sacrospinous suspension. It's going to be very easy. Don't don't get confused. It's very easy. Now I will show you certain images. There you will get the whole idea. Guys, before seeing those images, please watch this video. In this video, something is missing. What is that? Uterus is missing. What you can see is only a vagina with the vaginal vault. Now, watch this video. What can happen? See, the vault, the vaginal vault is prolapsing down. Okay, so that's what is known as vault prolapse. Now, what we can do for that vault prolapse? See, this vaginal vault, with the help of a mesh, is getting attached to the sacrum. So it is mesh sacral colpopexy. Colpo means nothing but the vagina. Okay, so with the help of a mesh, I am doing mesh sacral colpopexy. Okay, so this is one option which you can do for the vaginal vault prolapse. Or you can do uterosacral ligament suspension with the help of uterosacral ligaments. With the help of this uterosacral ligaments, I am suspending the vaginal vault. See, this is the vaginal vault. With the help of this uterosacral ligament, okay, I am just simply putting the sutures so that this vaginal vault is no longer falling down. So this is what is known as uterosacral ligament suspension. Now, let's talk about the sacrospinous fixation. I don't know whether you can see or not. See, the third image which I am talking about is the sacrospinous fixation. Very clear. With the help of a sacrospinous ligament. See, the ligament which you can see over here, it is a sacrospinous ligament, and this is the vault of the vagina. So now what I am doing is putting the sutures between the vault of the vagina and the sacrospinous ligament. So it's a sacrospinous fixation. So for vault prolapse, what you can do? For vault prolapse, you can do three types of surgeries, which are mesh sacral colpopexy, or uterosacral suspension, or sacrospinous fixation. But important point is colpo suspension. Important MCQ. See, in the name it's like, colpo suspension. Guys, colpo means vagina, suspension means we are simply suspending it. Okay, with the help of some sutures, we are simply suspending. Guys, colpo suspension, is it a treatment option for vaginal vault prolapse? No. See, the name simply tricks you. Colpo, okay, vaginal vault, getting suspended. So colpo suspension is a treatment for vaginal vault prolapse? No. Why? Because colpo suspension or Burj colpo suspension is something specifically done for stress urinary incontinence. Okay, so for stress urinary incontinence, we are going to do Burj colpo suspension, not for vaginal vault prolapse. For vaginal vault prolapse, we can do uterosacral suspension, or sacrospinous fixation, or mesh sacral colpopexy. Okay, now after this, let's continue. Okay, now what are these Kegel's exercises? See, these Kegel's exercises, they are not surgical things. Okay, so far we have discussed the surgical management for the uterine prolapse. Now what we are discussing are certain exercises which will prevent the uterus prolapse. Okay, which will prevent the uterine prolapse from happening. So what are they? Kegels exercises, important MCQ. So what exactly are these Kegels exercises? See, simply if you do exercise, your muscles will become strong. Am I right or not? Yes. In the same way, your pelvic floor muscles, the levator ani muscles, okay, they are the voluntary muscles. See, if you voluntarily contract those muscles, hold them up, and if you are simply relaxing, if you are doing this voluntarily 5-6 times a day, then the pelvic diaphragm will become strong enough to hold the uterus. See, when I am saying this, especially after the delivery. See, after the delivery, there is a chance that uterine prolapse can happen. So how can you prevent that? You can ask the female to do these Kegels exercises. So if the female is performing, if the female is performing these Kegels exercises 5 to 6 times a day, then her pelvic floor muscles, her pelvic floor muscles will become strong enough so that they can prevent the pelvic prolapse from happening. So these are what they will ask you about the Kegels exercises. Now let's discuss about the classification of prolapse. Guys, this topic is going to be very easy. Now let's see, the main important classification which you are using right now is the POPQ classification. What exactly is this POPQ classification? POPQ means pelvic organ, pelvic organ prolapse quantification. So pelvic organ prolapse quantification. See, it's a classification method which is used to classify the prolapse. So where exactly the prolapsed organ is. So based on the hymen, with the reference to the hymen. For example, let me show you. Here, guys, please concentrate. If this is the hymen, see, this is not the place where exactly the hymen will be. I'm just showing you for the reference. If this is the hymen, in reference to the hymen, we are going to say where exactly the prolapsed organ is. Is the prolapsed organ above the hymen or below the hymen? Above the hymen, how many centimeters? Or below the hymen, how many centimeters? Something like that. So by using hymen as a reference point, if you are classifying the prolapse, that is pelvic organ prolapse quantification system. And there is also one more classification which uses the same hymen as a reference point. That is Baden-Walker halfway classification. Baden-Walker halfway classification also uses the hymen as a reference point to say where exactly the prolapsed organ is lying. Now let's talk about the old classification, which is the Shaw's classification. See, Shaw's classification uses introitus as a reference point. Now let's talk about the Shaw's classification. Guys, Shaw's classification is using introitus as a reference point. We have already discussed. Now, according to Shaw's classification, there are 4 degrees of prolapse. First degree, second degree, third degree and fourth degree. All these degrees are based on introitus, where exactly the prolapsed organ is present. In reference to the introitus. See, if it is a first degree prolapse, means the descent of cervix below the ischial spine, but cervix still remains within the introitus. What does I mean by still the cervix is not coming up to the introitus? See, this is the introitus. For example, if I am talking about the first degree, this is the introitus. Now the cervix is still inside the vagina. It have descended down the ischial spines, but it is not up to the introitus. It's not up to the vaginal opening. That is first degree. Second degree means the cervix is coming up to the introitus, means it is coming up to the opening. So vaginal opening. It's now here. It's now near the opening of the vagina. Now, third degree is the cervix coming out of the introitus. First is inside the introitus, something like this. Second is up to the introitus. Third is totally out of the introitus. So third degree, cervix is coming out of the introitus. Now, this is not the fourth degree. We are going to call it as procedentia. What does it mean by procedentia? The whole uterus is coming out of the vagina. The entire uterus prolapses outside the vulva. This is the procedentia. So this is what is the Shaw's classification based on the introitus as a reference point. But the important classification which is using these days is the POPQ classification, pelvic organ prolapse quantification method, which is using the hymen as a reference point. If you know this much, this is enough. Okay, now let's talk about vaginal prolapse. Guys, so far what we have discussed about the uterocervical prolapse. Now let's discuss about the vaginal prolapse. Guys, this topic is going to be a very much easy. For that you have to concentrate very much. Okay, please concentrate. Guys, see this image, that this is vagina. We all know that this is the vagina. Anterior to vagina, what do we have, guys? Guys, please concentrate. This is the anterior wall of the vagina. Anterior to anterior wall of vagina, we are having this urethra and bladder. Okay, we are having this bladder and urethra. There is no doubt. Posterior to posterior wall of vagina, what do we have? Guys, I am dividing the posterior wall into three parts. What are they? See, upper 1/3, middle 1/3 and lower 1/3. Upper 1/3, okay, upper 1/3, middle 1/3 and lower 1/3. Now, see, in close proximity to the upper 1/3 of the posterior wall of the vagina, means this part. Okay, let me show you again. Yeah, here. What is closely related, guys? Posteriorly, there is this pouch of Douglas. Am I right or not? Yes. So, pouch of Douglas is in close proximity to the upper 1/3 of the posterior wall of vagina. There is no doubt. In the middle 1/3, the posterior wall is mainly in relation to the rectum. Yes. The lower 1/3 is in close proximity to the perineum. Okay, this is the perineal region. So, now, guys, please concentrate on the anterior wall. Now, let's talk about some abnormality with the anterior wall and the association with the conditions. For example, if the anterior upper 2/3, see, I am talking about the anterior vaginal wall. Anterior upper 2/3 means this structure, anterior. Okay, let me clear it for you so that everything will be clear. Now, see, this is the anterior wall. This anterior upper 2/3. If there is a defect, what happens, guys? The bladder which is present anterior to it, it will fall back. It will fall back and it will create a depression or impression on the anterior wall. It will fall back. So that can cause what? Cystocele, mainly cystocele. And see, if there is a defect in the lower 1/3 of the vagina, lower 1/3 of the vagina is in close proximity to which structure? Urethra. Now urethra will fall back. That can cause urethrocoele. Don't worry, I am going to show you the videos so that the concept will be clear. So, if there is any defect, okay, let me show you again. If there is any defect in the upper 2/3 of the anterior wall of vagina, that will lead to cystocele. The bladder will fall back. Okay, the bladder will fall back. Now, if there is any problem with the lower 1/3 of the anterior wall of the vagina, the urethra, it may fall back, causing urethrocoele. But most of the time, whenever there is cystocele, urethrocoele also will be there. So, I can collectively call as cystourethrocoele. Okay, cystocele along with the urethrocoele. Now, okay, anterior vaginal wall defects completed. Now, let's talk about the posterior vaginal wall. Posterior vaginal wall is divided into how many parts? Upper 1/3, middle 1/3, lower 1/3. If there is any problem, okay, let me show you here. If there is any problem in the upper 1/3 of the posterior wall of the vagina, it is closely related to what? Pouch of Douglas. In the pouch of Douglas, what you will have? Intestines. So that intestines will fall something like this. Okay, the intestines are going to fall something like this. Okay, anteriorly. That is called as enterocoele. Okay, enterocoele. Now, if there is problem in the middle 1/3 of the posterior wall of the vagina, this rectum may fall something like this anteriorly. That is known as rectocoele. And lower 1/3 of the vagina, okay, now the lower 1/3 of the vagina is in close proximity to the perineum. If there is any defect in the lower 1/3 of the vagina, this perineum will fall down something like this. That is called as laxed perineum. So now let me show you some videos so that you will have a better concept. Now please concentrate here. In this image or in this video, you can see a cystocele, how cystocele is forming. Guys, the concept is to have a cystocele, there should be defect in the anterior vaginal wall. No doubt here. That too, upper 2/3 of the anterior vaginal wall. So please concentrate in this area, upper 2/3 of the anterior vaginal wall. See what happens. Okay, you can clearly see that bladder is falling down. Okay, bladder, it's falling posteriorly, and this is known as a cystocele. Okay, now let me show you one more time so that you will get it. See, there is no uterocervical prolapse. It is cystocele. This is the bladder. It's falling something like this. Okay, now in the next video you can see. Yeah, now please concentrate here in this video. Yeah, what's happening, guys? See, it's a rectocele. Okay, rectum, it is falling anteriorly and causing a rectocele. So rectocele, to have a rectocele, where should be problem? In the posterior wall, that too middle 1/3 of the posterior wall. If there is problem in the upper 1/3 of the posterior wall, you can have an enterocele. If you have any problem in the lower 1/3 of the posterior wall, you are going to have a lax perineum. Okay, now guys, now how we have to manage the vaginal prolapse? Anterior vaginal wall prolapses causing cystourethroceles and posterior vaginal wall prolapse causing enterocele, rectocele and lax perineum. How we are going to manage? See, management is very simple. For anterior vaginal wall prolapses, that is cystocele and urethrocoele, what you have to repair? Repair or make the anterior vaginal wall strong enough. So it is anterior, calpo means vagina, raphe means just treatment. So anterior calporaphy. Anterior calporaphy is the management for cystocele and urethrocoele. Now for enterocele, enterocele is something posterior. So now what we have to do? For enterocele, what type of surgeries can be done are Moscovite surgery, Halban repair and mechanical caldoplasty. Important MCQs. For enterocele, how you are going to manage enterocele? Enterocele is because of the defect in the posterior vaginal wall, upper 1/3. That can be managed with Moscovite surgery, Halban surgery and mechanical caldoplasty. Now, how you have to manage rectocele and lax perineum, guys? Rectocele and lax perineum, they are managed with posterior. Why? Because you have to repair the posterior wall. You are not supposed to repair the anterior wall. Anterior wall repair should be done for cystocele and urethrocoele. Now if there is rectocele and lax perineum, what you can do is posterior calpo perineorrhaphy. Why? Because there is also this lax perineum, right? So you are doing calpo perineorrhaphy, posterior calpo perineo. It's not simply posterior calporrhaphy. Why? Because there is also this perineum. So posterior calpo perineorrhaphy. It doesn't matter whether the female is a parous, nulliparous. It doesn't matter. She is a multiparous woman or nulliparous woman. She is a young woman, older woman. It doesn't matter. See, managing uterocervical prolapse depends on the age and parity. Am I right or not? Yes. Whether you have to do sling surgery, whether you have to do Fothergill's Manchester surgery, or whether you have to do Wadmayo hysterectomy or ring pessary, depends on the parity and age. But for managing the vaginal prolapse, parity and age doesn't matter for everyone. If there is cystourethrocoele, you have to do the anterior calporrhaphy. That's it. If there is a posterior, wall defects, or if there is a rectocele and lax perineum, what you have to do is you have to do posterior calpo perineorrhaphy. It's one and the same for everyone. Okay. Now vaginal prolapse also completed. The management of vaginal prolapse done. Now after this, there is a very small topic, but you can expect an MCQ from that. What is that? It is Delancey levels of uterine supports. MCQs will be coming from this area. Now let's talk. Guys, according to the Delancey levels, there are 3 levels. Level 1 supports, level 2 supports and level 3 supports. What are these level 1 supports? Level 1 supports are sacro-uterine ligament or uterosacral ligaments. Okay, see, it's very simple. We are coming from top structures to below structures. See, this is the cervix. Okay, the structure which I am showing you right now, this is the cervix. To the cervix, which ligaments are attached? Just tell me, guys. Transversely, what type of ligaments are there, guys? Cardinal ligaments, McEnroe's ligaments, or transverse cervical ligaments. Okay. Cardinal ligaments are the level 1 supports. Okay. See, posteriorly, which ligaments are there? These are the uterosacral ligaments. Okay, well and good. Now, see this canal which I am showing you right now here. This is the vagina. Now, vagina have two walls. This is the anterior wall. This is the posterior wall. Now guys, please concentrate. Anterior wall, I can call something like this. Vesicovaginal fascia. Why I am calling like vesicovaginal fascia? See, I shouldn't call anterior wall as vesicovaginal fascia, but what I am trying to put into your mind is, see, this is vesicle, urinary bladder, vesico. This is vagina. So in between them, there is this vesicovaginal fascia. Okay, well and good. Posteriorly, there is this rectum. So rectum and vagina. So it is rectovaginal fascia. So anterior to the anterior vaginal wall, there is this vesicovaginal fascia, and posteriorly there is this rectovaginal fascia. In between them, there is this vagina. Now, what I am trying to say, the level 2 supports are, the level 1 supports are what? Uterosacral ligaments and cardinal ligaments. The level 2 supports are rectovaginal fascia and vesicovaginal fascia. Apart from them, there is also one more level 2 support. What is that? I can't show you in this image, so that I am showing you one more image. What is this? See, this is the cervix. Here is the cervix. See, to the cervix, which ligaments are attached? It is the transverse cervical ligaments and the uterosacral ligaments, which are considered as the level 1 supports. Okay, well and good. Now, level 2 supports are what? Rectovaginal fascia and vesicovaginal fascia. Okay, well and good. One more level 2 support is there. What is that? See, these structures. Okay, these structures which are present side. What are those structures, guys? They are known as arcus tendinous fascia. Okay, so level 2 supports are arcus tendinous fascia, vesicovaginal septum, rectovaginal septum or rectovaginal fascia. Okay, well and good. Level 1 supports are cardinal ligaments and uterosacral ligaments. Okay, well and good. Now, what are the level 3 supports? Guys, please concentrate in this image. The level 3 supports are the perineal body here. See, perineal body also supports the uterus. Okay, all the muscles which are attaching to the perineal body, they will support the uterus. But for now, what are the level 3 supports? Perineal body and see, please concentrate here. This transverse muscle, which is something coming like this. Okay, this transverse muscle. What is this muscle? It is the transverse perineal muscle. Okay, deep transverse perineal muscle forming our urogenital diaphragm. Okay, that's the level 3 support. Okay, so urogenital diaphragm and perineal body, they are forming our level 3 support. So level 1 supports are at the level of upper 1/3 of the vagina. Yes, upper 1/3 at the level of cervix. Level 2 supports are at the middle 1/3 of the vagina. Anteriorly, vesicovaginal septum, posteriorly rectovaginal septum, sideways it is arcus tendinous fascia. Now level 3 supports are at the lower 1/3 of the vagina. Which are they? They are perineal body and the urogenital diaphragm. Now why I am saying this? Because defect in level 1 will lead to what? See, defect in level 1, which means the higher structures, the uterosacral ligaments or the transverse ligament are not proper. They are not tight enough. They are not able to hold the uterus. So what happens? There will be vault prolapse or uterocervical prolapse, or there can be enterocele. If the transverse ligaments or the uterosacral ligaments, if there is a problem with those structures, what happens, guys? There can be uterocervical prolapse. The cervix can come down, something like this. Okay, the cervix can come into the vagina, that is cervical prolapse. Okay, so there can be cervical prolapse or uterocervical prolapse, you can call. And there can be enterocele above structures. There can be enterocele. Now, there can be vault prolapse or apical prolapse possible. If there is arcus tendinis fascia defect, vesicovaginal septum defect or rectovaginal septum defect. Guys, think logically and say. Please concentrate in this image, guys. Anteriorly, what do you have, guys? Anteriorly, there is this vesicovaginal septum. If there is problem with this vesicovaginal septum, what you can have? You can have a cystocele or even you can have a urethrocoele. So cystocele and urethrocoele are possible with the defects in the vesicovaginal septum, which is a level 2 support. Okay, and a defect in a rectovaginal septum can lead to a rectocoele. True. Okay, so that's what I have shown you here. Say defect in any of these level 2 supports can cause anterior and posterior vaginal wall prolapses, which include cystourethrocoele and rectocoele. It's not just cystocele, also it's mainly cystocele. Okay, it's not a urethrocoele, it's a mainly cystocele. Defect in this vesicovaginal septum mainly causes the cystocele, not the urethrocoele. Why? Because urethrocoele is something seen. Urethrocoele is something seen, especially if there is a defect in a urogenital diaphragm and perineal body. Okay, so if there is a defect in this urogenital diaphragm and perineal body, like the below structures. So below structures means, for example, please concentrate here. Below structures, there can be a possibility of anteriorly urethrocoele and posteriorly laxed perineum. Okay, see, what I am trying to put into your mind is, I am just summing it up. If there is a defect in the above structures, prolapse can also be happening in the above structures. What does I mean by? If there is a defect in the cardinal ligaments or uterosacral ligaments, prolapse will be happening in the organs which are more above. That is, the cervical prolapse can happen or the apical prolapse can happen. If there is defect in the middle structures, that's the middle 1/3 of the vagina, you can expect a cystocele and even you can expect a rectocoele. If there is a defect in the lower structures, that is the lower 1/3 of the vagina, that is the perineal body and urogenital diaphragm, you are going to have urethrocoele anteriorly and lax perineum posteriorly. Okay, we have discussed all the important topics and even we have discussed the management for the vaginal prolapse. I hope the lecture is helpful. Thank you.